And now, without further ado, I'd like to introduce John Beavis from Plant Moran.
Good morning, everyone. Again, I'm John Beavis with Plant Moran. I'm the leader of the firm's not-for-profit practice. I have the pleasure today of introducing Mr. James Haveman. Mr. Haveman is the director of the Michigan Department of Community Health. He was appointed to that post in September 1st of 2012, and he's working with Governor Snyder to move forward the health and wellness agenda for the state. He previously served as director of the Michigan Department of Community Health from 1996 to 2003, and before that, he was the Department of Mental Health director as well. Interesting fact, I thought, in 2003, he was appointed by the White House as the Coalition Provisional Authority Senior Advisor to the Iraqi Ministry of Health, and he served as Iraq's acting Minister of Health for 3 months. And he really put together a sustainable and equitable healthcare system for the country. Prior to his involvement with the state, he served as Executive Director of Bethany Christian Services. He was Executive Director of the Kent County Community Mental Health Program and Executive Director of Project Rehab. He's a social worker by training. He's a graduate of Calvin College with a master's degree in social work from Michigan State University. And so without further ado, I know there's probably a question or two you might have today for him. I will let you get started with Mr. Haveman.
Well, it's the first time I've ever been introduced where I had to kind of come out of the chute, so I appreciate it. And it's good everybody's here today, and I want to welcome you and thank you, John, for the introduction. And it's when I got in my car this morning, it was 4 degrees above zero, and I think we're headed to some real cold weather again. One of the more interesting things about working with Rick Snyder is that everything's electronic. You realize that he manages this whole state with a mini iPad, and he puts a lot of us over 30 to shame. Where we still hold on to paper and we hold on to these files. You walk into a meeting with Rick Snyder with a file, and if you try to give him just a sheet of paper, he won't take it. He just says, send it to me by electronically. If you're meeting with him in the morning, you send him the night before by 3 o'clock, he has read it and absorbed it. We recently put in a SIM proposal, the single kind of a model for how we see healthcare being financed in the future in Michigan, and it's 300 pages long, and I had to get it in early enough because he wants to read it, and then he'll read it, and then he'll call me up and he'll have questions about it. So it's an impressive way to manage government in all the departments. But I've worked, for 12 years with John Engler, and then I worked with Paul Bremer in Iraq, and then with Rick Snyder. And these are 3 very, very smart people who have this capacity to absorb a lot of information in a very short period of time. They also are fervent readers of political things, but also the kind of the policy wonk things that we really enjoy reading about. The difference between the 3 of them are that when Rick Snyder gets to an annual report, where most of us just read the hello from the president and the chairman, he'll read all the detail that's behind it and enjoys that. But they also have this capacity to remember things. Their mind just it works like all that information's up there. If you watch Rick Snyder in the State of the State the other night, he gave that whole speech without hardly looking at a note. The only time he really looked at a note when there was a name or somebody he had to put out. But it's just an amazing capacity to pick and choose in a relaxed way what you're going to say and to pick the points that you're trying to make. And it's a real skill, and it's a real pleasure working for them. The other skill that all 3 of them have is they have this unique ability to delegate and to find good people, tell them what they want to do because they have the vision in their mind, and let them go. And then it's kind of like a need to know. With Snyder, it's a little bit different because he uses dashboards, so there's a lot of measurements. But the one thing that he's doing that both Engler and Bremer didn't do is a whole lot more emphasis on employee engagement. And this is a kind of a new thing for me, where you do a lot of employee surveys and you find out the dashboards, you find out what people are happy with, what they're not happy with. Is communication flowing? Are the messages that you're trying to send as a CEO getting down to all your staff? And do they feel like they're engaged in the process and the mission and the vision of where you're trying to head? And if you're not doing that, I'm believing that if in the nonprofit world, if we really want to get to the point where we want to compete with the big players out there and the for-profits, we have to do a much better job in employee training, employee recruitment, employee retention, engaging employees in strategic planning, and engaging employees with ownership, entrepreneurship, where we're headed, so that they feel they're invested. And that's something that I have really enjoyed being part of, and I think it's something that we're all going to have to get used to doing more in the future, and it's going to be a cornerstone for a successful agency. I thought the State of State had a lot of great information in it. Like most speeches, you got to go back and read the print because it goes so fast with the stuff that they're rattling off. Not only see that this is a rebound state, but also kind of where we're headed. And I'm going to talk a little bit about that today, and talk a little bit about the type of times that we're in. Our budget begins in the joint House and Senate appropriations on February 5. Our subcommittees for appropriations begin on February 12. And we're basically done with our appropriations in both the House and the Senate by about the second week of March. So the budget's moving very quickly this year. There's time that's already been posted for testimony and for public input. But I dare say by April, May, this budget's going to be done, because you got to remember this is an election year, and people are going to want to get out of Lansing and start campaigning. So things are going to start moving fairly quickly. Our budget, I'm very satisfied with the 2015 budget. You're going to see some interesting new initiatives in there. If you heard the governor, he talked about the elderly being a no-wait state. This is going to be a great year for seniors. And after today, this is going to be a great year, continue to be a good year for children and adults as it relates to health and wellness. We're releasing the Mental Health Health and Wellness Commission report today. We're doing the media roundtable at 2 o'clock, I think, or 2:30, and then doing a joint House and Senate Policy Committee meeting at 3. This is the one that Lieutenant Governor Calley and I, along with Senator Warren, Senator Caswell, Representative Kavanaugh from this area, and Representative Laurie are part of. Get a hold of this as quick as you can, because there's going to be some very practical, reasonable, new ideas in there for both adults and children, particularly as it relates to the interaction between DHS and juvenile justice and community mental health. And there's going to be some new, we're going to try to put into practical reality what's going on in the field today of integration of healthcare. So look for that. And if you want a report of that, you can call my office and have Nancy send you a copy of it. But most of your organization associations, I think, will be getting the report out. It's short, to the point, 20 pages. This doesn't look like the 204 commission that some of you were part of. This has a whole new kind of look to it. And I got to tell you, Lieutenant Governor Calley has been a very committed. He's a parent of an autistic child. So, as Liz Bauer and other people know, when you're in this work and you have a developmentally disabled child or mentally ill child, this is no more than just being a job. You got purpose. Vita and I were talking about her family situation, and it's personal. It's something that you that you really want to have work because you're engaged in it. And that's why consumers continue to be front and center in what we're trying to do. I've never seen a more frustrating, tense, anxious time in healthcare that I've seen coming back to the department. One of the reasons when they called in August of 2012, would I come back, is that because I think this is a great time to be engaged in this movement. There is more conflicting ideas and new ideas and entrepreneur ideas and fear about the future and will I survive, will there be mergers, will there be affiliations, how am I going to posture myself, legacy is different than what it used to be. There's a new language, new partnerships that people got to form. Much of this which is new to many of the people in this room, some of it's not. But there used to be the saying that fences make good neighbors, and I've been kind of playing off the theme lately that we got to get rid of the fences, and that we've had way too many fences and way too many silos and way too many independent ways of thinking, and this whole merger of mental health and physical health. I can remember as a youngster in the 50s when I was working at Butterworth Hospital in Grand Rapids, they had an A West, they had a psychiatric ward. And the only thing that people did is to really wait for the food that I brought in every day. And I would walk this gauntlet of people just waiting for the food, pulling the carts. And I think early on it set my my mind to say, this isn't right, there's a better way to do this. But back then, and many of us, and many in this room were part of the whole community mental health movement. We developed a whole carve-out, a whole separatist movement, because the physical care folks wanted nothing to do with people who are developmentally disabled or people who are mentally ill. And we went on our way, and the mental health system developed its system. We developed various private agencies. Many of us were part of that, and very successfully. Many of you are in this room. And then all of a sudden we began to see the connections between physical care and mental health, and hospitals all of a sudden are all getting re-engaged in the work that you do. In fact, many of them would like to do more of the work that you do, because they see that many of the people that are being discharged, who they have to pay for heart problems or pneumonia or whatever, when they're admitted within 30 days, a good number of those come back because of depression, not because of the reason that they left the hospital for. They began looking at their high utilizers in the ER rooms, and they found all this underlying mental health issues, some of which they never saw before, or much less didn't want to see, but were so willing to call you and wondering why you weren't taking care of things. And so all of a sudden, they're on this mass interest to engage with many of the mental health people as to how you can be part of our system. And part of the problem is a lot of the mental health community doesn't know the language, doesn't know the culture, doesn't know the calculating of dollars and per member per month, and nor the lingo of how the physical care hospital people work. But this is something that you're going to have to learn real quick, and you're going to have to adjust to real quick and adapt to real quick, because you need to partner with the broader healthcare community, because if you don't, they're going to do it without you. And that's why, my push for a lot of CEOs and people in the nonprofit world right now is not to be intimidated by the big managed care companies or many of the big players that are out there, but to go to them, and many of you had, and say, how can we form a partnership, and how can we play together in the same sandbox where both can gain? And what you have to show them is that you bring a value addedness to the party, whereby it's something that they would want to buy and they would want to use. And if they don't see the value in it, they're going to go elsewhere. And at the same time, as a department, we're moving our thinking away from a HEDIS score. It's one thing for me to say, okay, so they're doing a cessation class and they did it for smoking for 1,000 people and they get a score for that, but if only 50 quit smoking, what's my investment? So you're going to see us moving to measure more of the outcome, not necessarily the process. And that's going to be a switch, and that's going to be a change for a lot of agencies and a lot of our providers, but that's the way we've got to go, because it's kind of that value purchasing theme that many of us want to go for. I don't know what's going to happen with Congress with the Affordable Care Act. My sense is that there's going to be a lot of tinkering going on, and I hope the tinkering isn't into our disadvantage. For instance, I hope they don't start messing with provider taxes. Provider taxes are really key to how we finance a lot of the Medicaid in this state. A lot of the arrangements we have with nursing homes, a lot of the arrangements we have with managed care programs, a lot of arrangements we have with hospitals is pretty creative financing. But at times Congress says, well, we don't want to do that. You know, if they want to get the primary care doctor money out there continuing under Medicare, they're going to have to find $150 billion. Where are they going to find that? That's why through your national associations, I think you really have to stay vigilant in what you're trying to do. I don't want them to go after GME, which is something, graduate medical education, that many of them like to go after. Although I feel we got to do a better job coordinating GME in this state. There's about $700 million of graduate medical education that comes into this state, little of which we have any control over, of saying how can we shape that GME to meet the future needs of the future when I look at workforce development stuff. Scope of practice is going to continue to be a huge conflict issue with the Michigan legislature, with the interest groups, and with us as a department. I tend to favor a much more liberal approach to the scope of practice because my focus is on access, and many of the associations and medical groups and dental groups, you know, claim that this is our turf and this is our area. Every time I go to the dentist after the dental hygienist cleans my teeth and does examination, I say, do I have any cavities? She says no, and I said, when I'm going to go. And she said, well, you can't go. I said, well, why not? Because the doctor has to see you. Well, he spends 1 minute with me, gets $55, where you know, she told me what I needed to know. So all these things are going to come into conflict. You know, look at the debate that took place in the Florida Senate when Mark Jansen threw up this nurse practitioner issue. If you ever want to have fun, go back and look at the voting. It finally passed by a couple of votes, but it was Democrats, Republicans on both sides, conservative, liberals. It got very conflicted. And then I don't know what's going to happen when it goes to the House, but this is a holy grail for a lot of the professional organizations out to protect their turf. At the same time, I see the health statistics of this state continually to go the wrong way. And I've said this in talks before, and I'm really tired of always being 35 in this and 34 in this and 31 in this, and a lot of it has to do with chronic illness. And we are not getting a handle on our chronic illness. 70% of our healthcare dollar goes to chronic illness. Much of that's preventable, but we seemingly just can't get a grasp of it. And it's they did a survey at Michigan about people smoking coming in for surgery. 9% of the people who come in for surgery on commercial patients smoked. 50% of the Medicaid people smoke. If you come into surgery and you've been smoking, we're finding out that if you quit drinking, you quit smoking for a month ahead of time, you lose some weight, your chances of survival after that surgery are much better. So our mortality rates and our lack of response rates to surgery are poorer because a lot of the conditions of the folks that we work with. We have 4.5 million people in this state who are way overweight. We have 400,000 children in the state who are obese, and you know that leads to other chronic conditions. So we got many people in the state who have multiple conditions of health care, and many of those are people who are mentally ill, and many of those are people who are developmentally disabled. And now we're beginning to see the whole interconnectedness between physical health and mental health, and it's something that we got to come to grips with, and there's an urgency to this. And I just can't seem to get people to feel the urgency of it, because if we want to really, if we would just roll back to obesity rates in this state till 5 years ago from where they are right now, we'd be saving hundreds of millions of dollars in this state. But we just don't seem to grasp that we really got to do something, particularly as it relates to chronic illness. And it's something that you're going to see us crank it up. You're going to see us get more engaged in it in our contracts with people, contracts with providers. to be paying attention to these type of chronic illnesses and to do the type of screening that needs to be done. I think the hospital revenue in this state's continue to decline. Much of what goes on in hospitals is elective as people get more insurance policies that are more individually focused with high deductibles. People are going to make choices as to what type of surgery they want. We have 7,000 empty beds in this state in hospitals. It's one of the reasons why, I continually not to support through the CON process building the new McLaren Hospital. We don't need a $300 million hospital. Just when we already got 8 hospitals, we got 700 empty beds within a reasonable amount of time driving. You're seeing the hospitals move to more surgical care centers, more ambulatory care units. There's going to be less people in hospitals. There's going to be the day when bypass surgery would be done in a surgical care center, not at a hospital. You're seeing different thinking going on in the hospital world right now. We spend a lot of money on dialysis. It's very expensive forever. We spend a little emphasis on organ donation. It's easier and cheaper to do a kidney transplant than to keep somebody on dialysis. If you just want to experience that, spend some time at the infusion unit at Detroit Medical Center, and you see the young people, and you see the kids, and you see the young adults just waiting for kidney transplants. And so, I know the Secretary of State, and we've all been involved in organ donation, but I think we got to become more of in tune and practice what we preach. It was very interesting to me to see in the Healthy Michigan Plan that advanced directives are part of the Healthy Michigan Plan, and I'll talk about that in a minute. And these were supported by conservative Republicans. If that would have been brought up 12 years ago, it would have never flown. But it's really ingrained in the reality of the bill because people see what we spent on the last days of life and the number of people who are terminal who end up in intensive care units and dying when they should be part of palliative care or hospice. And I think the average for hospice is probably less than 3 or 4 days in this state, where it should be longer than that. And we got to get engaged in having the conversation in our families earlier on. The governor put out a regional approach. Take a look at his regional map. Through a process, Bill Rustam and his staff have put together a map that shows 10 regions in this state. They went through 80 different agencies in state government and found we had 80 different ways of looking at the state. It looked like spaghetti. People don't think that way anymore. People think regionally. People think nothing about going over a Wayne-Oakland County line or Macomb line or into Livingston County or Ottawa and Kent County and Clinton, Ingham, Eaton. And so we've got to think that way too. But in some of our human services, we've really split people where you can get services here, but you can't get it across the line. I hear of way too many families who are looking at what a community mental health board offers, and then they decide to move accordingly. So we've got to really work on some standardization, but we also have to maybe change what we have been doing and saying this is what we need to be in the future. The Healthy Michigan Plan, we did get the waiver at the end of the year. Steve Fitton, as you know, our Medicaid director, had a heart attack in December on a cruise. He's back. He's starting part-time back this week. So we're very thankful for that. But his staff has done a great job staying on top of this thing. We still are looking for an April rollout. I'm beginning to feel, and some folks talked to me today about where we are in our timetable, where we are in our rollout. I know we have a lot of, and many of you are part of enrollment, not only for the healthcare.govs, but also what does it mean for the Healthy Michigan Plan, where we're going to have to enroll 322,000 people and potentially up to 477,000 people. I just want to tell you that we're working on a marketing plan. We need to tie up the IT relationship between the federal government and the state programs with Bridges and CHAMPS and our systems internally. We then got to make sure that we're set to go. We'll be working with all the enrollment people in this state. I don't think you're going to see a lot of action on that till we sit down with people in February. We are still looking at an April startup date. I have to make sure, and you can understand this, is that I don't want to experience what Secretary Sebelius experienced in Washington. one thing that the Healthy Michigan Plan has done, it's put the Medicaid programs, put the department into an absolute fishbowl. And the other thing that's happened is that many senators and reps finally realize that we're a $15 to $17 billion budget, and that we're a good part of the budget of the state of Michigan. So all of a sudden, they're all interested for various reasons in our budget. And we got people now wanting to be on our appropriations committee, where before it was tough to get people back in the 90s. So there's going to be a lot of accountability, and I have a whole big checklist in my office of all the things that we've got to do and expectations of transparency, and we've met them all to date, and we'll continue to do so. But we're going to have to really show that that we reduce uncompensated care in the hospitals of some degree. We're going to have to show that the cost shifting from the uncompensated care to the premium market either slowed down or decreased a little bit. I mean, we've got to show all these things, so we're going to have a pretty robust evaluation process of the Healthy Michigan Plan. But we're going to build this on the managed care programs that we already have. But they're going to be partnering with the community mental health programs like they have in the past. So there's going to have to be a lot of networking and a lot of contracts finalized and a lot of expectations done during January, February, and March. But I think, we did not get immediate effect when that bill passed. So I have no money to do enrollment. I have no money to do marketing. We're going to have to find some resources. But the money doesn't flow into our budget till April 1. What makes it more complicated is that because it didn't get immediate effect, that they took more general fund money, about $70 million more general fund money out of the budget that I need back in the budget because we didn't start January 1. We're starting in April. So I've got to go through the politics to get the votes to get that money back in. I believe that we'll get there, but I also have a hole of about $110 million in the budget because of the HICA tax, the claims tax, which was short, and that's all tied up with the whole no-fault discussion that's going on, and that's a whole different discussion that's going on. So we have many pieces that have to come together. As a manager, I always think very sequential, and I know many of you in this room do that as well, but I think as CEOs, we have to think sequentially, and so often it's too easy to get so overwhelmed with all the pieces. I happen to be the son of an architect, and I think I learned early on from my dad that when you build a building, you get a solid foundation, and then you build on top of that. And it's always good to have a solid foundation, and it's kind of like Legos. If you add a program, you can add a Lego. If you lose a program, you can take the Lego off, but you need that solid foundation so you're able to adjust and adapt accordingly. And I think in the nonprofit world, we got to get better at becoming more quick at our feet to seize the opportunities that are coming down. And I'm always amazed, and I'm going to be interesting to watch when this Wellness Commission report is released today, how many people come up with ideas. Now, I was very encouraged by when I put that innovation money out for $1.5 million to get some innovative ideas. We had 166 ideas come in. We funded 42 of them, but I got another $1.5 million next year for some innovation money. So, I mean, everybody's always had it. If I just had $30,000, I could really do this. And we want to try some things. And I was really impressed with many ideas that came in there. But I'll also be encouraged to see how many people come up with ideas on the diversion of children and adults from the criminal justice system, but also how many come up with how they can implement many of the recommendations that we're going to have in this report. The enrollment through the Healthy Michigan Plan will be through Maximus, much like the My Child program is. There'll be some questions to get some early identification of enrollment information. Then people are going to have to pick a plan that they're going to be part of, and they have to be seen by a health professional within 60 days. And within that 60 days, once they're seen, and then they set up a contract where they're going to work on 6 issues, relates to some chronic conditions. And if they show that they can make a difference in working on those chronic conditions, they can get reduced premiums and they can get reduced co-pays. So there's a lot of issues in here on personal responsibility, and after 48 months on the program, they got a choice. They either can go to the exchange or they can stay on the Medicaid program. People as of January 1 who were under 133% of poverty and went to the exchange to get their health care or get the subsidy will be moved into a Healthy Michigan plan come April. Then they're going to have to pick a provider. The providers are beginning to pull a lot of their thoughts together, how they're going to do this, because we want a uniform message out there so people don't get confused. We basically have finalized the provider or the beneficiary handbook. And this is not a Medicaid program. As you know, we don't use the word Medicaid expansion. This is a Healthy Michigan plan that is designed, has a Michigan flavor to it, and it's going to be funded and by leverage by the funds from the Affordable Care Act. There are 1.2 million people uninsured in this state, folks. 570,000 of those are working. And this is the group that we're going to zero in on. And these are the people making between $8 to $12 an hour. There could be folks who work for you who are going to benefit from this. There could be people who are working in nursing homes who are going to benefit from this. The governor talked a lot about aging. Look for some, this is going to be a good year for seniors going to a no-wait state, as he said, which I think we should do. Our motto is, you're going to see us change a lot of the discussion of infant mortality into healthy babies. You're going to see a lot more emphasis on nurses visiting programs where people go into the homes, help people parent. You're going to see major emphasis in the budget on the preschool, but there's this whole group that's up to 2 years old, where a lot of formal stuff is done, that we've got to do a lot of work, especially with high-risk children. You're going to see recommendations of the commission about we got to stop this passing kids around between agencies, between Hawthorne, between foster homes, between their homes or their family, and nobody's coordinating it, and nobody's making sure that something positive's happening. You're going to see more emphasis on blended money, blended dollars. We talk about it, but we're going to practice it by changing some of the codes. And we've got to change codes that really facilitate the whole movement to the integration of physical care and mental health. We got a lot of good things going where people are working next to each other, but there's a lot of things we got to do is to bring some of the codes together. The whole duals project is moving. We're, with 200,000 people in the state, when we spend $8 billion on the mentally ill or the people on Medicaid and people on Medicare, Wayne County is one of the communities we're going to try this in. And we're going to bring 100,000 people together in the pilot, see if we can do a better job coordinating care. I think we can, and if we can save some money, that means we can try some new things with many of the people who are getting both services. Keep your eye on that whole state innovation model, the SIM model that's going into the federal government, because out of that's going to come 3 test sites where we're really going to test site community hubs. The hardest people have, and Randy and I were talking about, the hardest thing people have is navigating our system, the complexity. One of the things that I would like to try, if anybody's got an idea, bring it forth. I would like to try getting something out there to families who just don't know what to do. And they don't know where the community mental health board is. They don't know where the private counselors are. They don't know what to do. They're at their wits' end, and this is early on in a crisis, and many families just need help parenting. And if they could just call somewhere who could, and I don't know if that's 411 or, too many of them call me and you, and there's got to be a better way that we can kind of get things out there in rural communities and urban areas where people know where they can go. Because one thing we've lost in our communities nowadays is a sense of community, where people knew what was going on next door, because in many communities there is no next door. There's a house across the street, there's a house down the street. But we've got to figure a way to begin tying communities together or offering help and support when people need it. So integration is going to be huge for us. The Health Endowment Fund, I saw Lynn Alexander here. She was appointed by the governor to it. The Health Endowment Fund is the $1.8 billion fund that's going to be put together over the next 18 years of the Blue Cross Blue Shield movement to mutualization. That fund gets its first payment in April of, I think, $50 million. That'll start paying some grants next fall, I believe, but it's going to be focused on children and seniors. And this is a great opportunity. This isn't like funding ongoing programs, but this will be funding new ideas, creative ideas, innovative ideas, and look for more information to come out. And congratulations to Lynn for being appointed to that as well. Analytics is going to be huge. We do not spend enough time looking at the data we have in our own agencies to find the trends and the directions that we need to go and to find out what's not working. One of the hardest things, and Engler used to talk to me about that. He said, well, how come it's so easy to replicate bad programs? And we just got to figure out ways to let programs die that no longer are doing it and shift to some new creative ideas that's more responsive to what people want. So think creatively, and sometimes, and you're all on boards, and sometimes you don't change a program because you sit next to the board member that funded a program that named a building after them, and nobody wants to change it. And sometimes we just got to deal with it out front and deal with it accordingly. But analytics is huge. I have a data warehouse with $35 billion pieces of information in it. You all have your data warehouses. We do not spend enough time learning from that data. Now, you're going to see some very specific recommendations in the commission on people who are homeless. You're going to see some aggressive goals set for new housing, John Van Camp. So, you know, there's some things coming out of here because we can do a better job than have mentally ill and substance abusers living on the street. And I think we've proven that with some of the programs here, particularly, and then you add the veterans to it. What's been done here in Wayne County, what's been done here in Battle Creek, what people are talking about in Grand Rapids. And we just got to work much closer with our partners at MISTA, and we can come up with some creative ideas. Prescription compliance, you're going to see some new emphasis on that by the department. You know, about a third of the people that get their drugs from the hospital never use them. About a third of the people that call their drugs into Rite Aid or CVS never pick them up. We have a huge compliance problem in this state, and we got to work on that. And you got to work on it at your agencies to ensure people are taking their drugs. My biggest fear going ahead is how people are going to navigate this system. I kid around sometimes and say, well, someday you're going to go to the mall and you're going to see a store having, much like Verizon does, just options for health care. People are going to how do people pick and choose? How do people not get confused? People are very confused with the discussions of the Affordable Care Act right now, and how are you going to navigate out of this? I don't think much of the Affordable Care Act is going to change unless the Republicans take the Senate in 2014. But much of it's pretty bedrocked in place, and the Republicans have tried 42 times in the House to change it. There's been minimal changes in the Senate. But, and the numbers of people signing up have certainly increased, and I think at Michigan, we're about 5th or 6th in the country for signing up people, but it certainly hasn't met the expectations that people thought it would when it was rolled out. And that's why I'm being so cautious to make sure when we roll this out, it works, because I got to make sure, because I am not going to sit in front of an appropriations committee or an investigative committee in the House of Representatives or the Senate in this state as to why it didn't work. We're going to make sure that this works, and we're not going to risk anybody. We're not going to risk your reputations. We're not going to risk our reputations, and particularly send false messages to our consumers that things aren't working out as we said they would and how they planned. The language, we all have to work on that, folks. We all have to learn how to work with the tenets of the world. We have to watch the mergers. I think many of us and in this room will be looking at mergers and new affiliations and new models in the future. I think we got to be careful that we don't move too fast in change and stampede to get to the ending point before there's a sequential pattern timetable to get there. I'm a strong believer in private agencies and partnering with the public sector. I think private agencies bring a whole lot of relationships with the United Way, with private contributors. Go to look at the charity ball that they had at the auto show with the amount of people that came out and supported causes. Many of you in this room have tremendous fundraisers which add to the state and federal dollars that come into the state. I congratulate you for that. Keep doing it. It's hard work, I know, but you're an important part. The bedrock of the delivery system in the state is a private-public relationship, and we got to continue to support it and continue to endorse it. What I think the public sector's got to do is be clear on its contract expectations with the private providers, and I think what the private providers got to do is be able to show the value addedness, and we've got to do a much better job at Rotary clubs and Kiwanis clubs and with other groups, letting them know what we do. I'm always amazed how quiet and silent we are when we're part of an $80 billion industry in the state called healthcare. And, you know, Automation Alley is important. The auto industry is important. But we're an $80 billion investment in the state. Over 500,000 people are employed by the nonprofit sector. We got a lot to champion about, but we don't do a very good job at that. Telling people what we do and that we made a difference in that neighborhood and we made a difference in that family and we made a difference in the result of that child who is having a challenge. And I think that's what we got to rally around and get our messaging out better. And I think we can do that if we all do our own part. So I just want to tell you that one of the reasons I wanted to come down, and I appreciate Dennis and others putting this together, is that I want to thank you in the nonprofit world and in the public sector for what you do. We can't do this without you. I see my job at the state is getting as many resources I get from the Michigan legislature so that they can fund to a state, so we can fund programs that is very multicultural, is full of disparity, and some of our health disparities that really should embarrass us, folks. And we got to continue to work on those. And what we're beginning to find out that there's some health disparities because people are living in poverty, people are living on the streets, they don't have running water in their house, they don't have the nutrition that they need, they don't have the food balance they need. That's why you're seeing a lot of this wrapping services around schools, where schools are becoming kind of a hub for a lot of families, and we'll continue to support that. The trick is, how do we get the community mental health folks more engaged with DHS? And because, as you know and I know, we're often dealing with the same kid, and we bounce them around. So you're going to see a lot of emphasis in trying to change that. So I'm optimistic going into 2015 and 2014. This governor is very interested in mental health issues. The last thing I'll say about coming back the second time is that this governor spends little time wondering why we did it this way in the past. And he gives full permission to say, hey, we should have done it differently. We made a mistake. Let's just align it. Let's change it. Let's move forward. You're going to see some things in this report that I think are going to fix some things that we missed 10 years ago. And that's okay, because it's the right thing to do. And nobody's finding fault, nobody's finding judgment. We're just trying to do what's best and trying to be consumer focused. That's a lot of freedom, and that's the atmosphere that we did on this commission. And no recommendation from the commission that we're releasing today could be made unless it was unanimous. That means both Democrats, Republicans, Cali and Haveman had to agree on it, and we were able to do that. And I think that's positive. And I think that's the positive momentum that's going to take us forward into the future. So thanks a lot for what you do. We got some time for questions and answers, and I'll give you the answers if you give me the questions. So, and quite honestly, feel free. I mean, I can handle it, and if I don't know the answer, I'll tell you.
Thank you, James.
The only one who called me James was my mother, and that was when she was mad at me.
Jim, okay. Jim Haveman, thank you. Well, thanks again for, I think you deserve a round of applause for that update.